So good morning to everyone. It's Thursday morning, means we have fun to enjoy science, because what can be better as having fun with what you like more, and in fact to listen to great talks. And today is my pleasure to have Dr. Loreta Nastupil. And of course, I want to say thank you first of all to all of you who are attending. Without you, such webinars cannot happen. To say thank you to Dr. Giulio Draeta, Ignacio Disturba, who are basically hosting in CSO and in translation molecular pathology this webinar. To say thank you to my co-host Alessandra Ferraioli, and of course to Emily Lang and Anton Blender, because without their technical support, again, nothing can be done. And with this, let's welcome Dr. Nastupil. Most of you know her because she's another clinician scientist doing a wonderful research in MD Anderson. She graduated from Southwestern, and then she went to very great places for training, to Emory and to University of Washington in St. Louis. She is now the deputy chair of the lymphoma and myeloma department, and also she focused specifically on new drug development, and she's publishing a wonderful discovery on lymphomas, which we know very well are deadly cancers without a huge improvement. So it's a terrible need to help our patients. And in fact, Dr. Nastupil and her team is publishing wonderful news and wonderful trials to help these patients. With this said, thank you very much for being here, Dr. Nastupil, and we are very, very curious to listen to your talk. Thank you again, and good luck with the presentation.
Thank you. And I'm so excited to be here today talking about one of my favorite topics, which is the evolving treatment landscape in follicular lymphoma. Just a side note, so I have 5th grade students today that are taking their STAR test. And a moment that made me very proud is my girls said they were looking forward to today because it was the science section, and that was the easiest part of the test for them. So at least I know I'm doing something right. Please make sure you take the opportunity to submit some questions, and we'll address them in the Q&A section. These are my disclosures. So first off, is there an unmet need, and particularly a need for developing new therapies for patients with follicular lymphoma? And my first answer is absolutely. But I think we have to at least analyze where is the unmet need and how can we potentially address it. So in my opinion, if we could cure this disease and spare patients the anxiety of knowing they'll have a chronic illness that at any point could come back, and at any point they may need therapy that may impact their quality of life, a one and done treatment, I think, would resolve a major unmet need in this situation. But also, we have a huge spectrum of patients, from young people in their 30s and 40s to patients in their 80s. And we may approach them very differently depending on what their goals of therapy are. And so where could we address those needs? Well, it would be very helpful if we had predictive biomarkers that could inform treatment selection, because we actually have a number of effective strategies available. And again, we might approach someone in their 80s very differently from someone in their 40s. The other area of unmet need is we tend to focus most of our attention on later lines of treatment, which is generally how we pursue drug development, because the toxicity is probably going to be most justifiable in someone who has failed a number of prior therapies. But again, in a disease where the natural history may be 20+ years, is that the best utilization of our efforts to try and really change the treatment landscape? I may make a plug for testing newer therapies and even earlier lines of treatment. And the last thing I'll say, we need more efficient studies, because if we have a frontline trial in follicular lymphoma that launches today, it'll be 10 years before we hit our median PFS. I hope if we do our job correctly, in 10 years, the treatment landscape will be so different that the therapies we're investigating today will be obsolete. So just to demonstrate how complicated this treatment landscape is, this is a slinky plot of a number of patients that we've enrolled across 8 centers. Most of these patients were treated in large academic centers like MD Anderson, where they had access to novel therapies, including trials. But you can see the vast majority of patients are still receiving standard of care options. And so when we start exploring novel drugs in that 3rd line or later setting, we have to at least acknowledge that how they got to that therapy can be grossly heterogeneous. And so drawing strong conclusions, and particularly when we're looking for signals, if we fail to acknowledge that one patient may have got there through observation followed by rituximab monotherapy followed by rituximab and CVP, is going to be grossly different from someone who's progressing quickly through 2 lines of alkylator-containing therapies. And I think that's another opportunity for our real-world evidence where we're generating more expertise to try and understand these nuances, particularly as we launch larger studies. There is an unmet need in that most patients with follicular lymphoma are still dying as a result of follicular lymphoma. So there is a misconception out there that these patients are dying from competing risks of death. And even in the modern era, that's not true. So if you look at the survival curve, patients are dying not as a result of transformation to large cell lymphoma and not as a result of reasons unrelated to lymphoma, but as a result of follicular lymphoma. So despite survivals becoming more aligned with the natural history of this patient, they're still more likely to die from follicular lymphoma than competing risks. So again, that makes the argument, I think, in my mind, that we have a job to continue to develop effective strategies that are not going to result in toxicity that may also have an impact on quality of life. So I'll start by covering what's been done in the frontline setting. Those of you who are familiar with the follicular lymphoma treatment landscape, there is no new information here. And that's because, again, most new drug development is happening in that 3rd line or later setting, mostly because companies are fearful of going after a large randomized trial in a rare disease that will require a large number of participating sites, probably a global study that's going to have a median PFS readout in 7+ years. And as a result, there's a paucity of studies being done in frontline follicular lymphoma, which again, in my opinion, is probably where we should be focusing a great deal of our effort. What has informed the treatment landscape to date are these trials. So the STEEL study led to the utilization of bendamustine in combination with rituximab as one of the most common frontline chemoimmunotherapy approaches. The BRIGHT study was an American version of this. It at least demonstrated VR was as good as CVP or CHOP plus rituximab. Gallium explored replacing rituximab with a superior CD20 antibody, obinutuzumab, and it met its primary endpoint of a significant improvement in progression-free survival, but no difference in overall survival. And I think some of the toxicities, particularly among the bendamustine treated patients, has led to less adoption of obinutuzumab despite it being a positive study. Relevance is the first time that a non-chemotherapy approach tried to dethrone chemoimmunotherapy in frontline follicular lymphoma. And though it was a negative study because the non-chemo arm was not superior to the chemotherapy-containing arm, it did result in similar outcomes, and I'll show you an update to that study as we had a pivotal role. And then the PRIMA study looked at continuing out the CD20 antibody for 2 additional years could result in a significant improvement in PFS versus observation, but again, no difference in overall survival. So I will say most places in the U.S. will still pursue that maintenance therapy. In the era of COVID, I think that's now raised questions about should we continue CD20-based therapy beyond remission, particularly if that's going to increase risk for infectious complications. So this was the relevant study that I alluded to, replacing chemotherapy as our most common frontline approach for patients with untreated follicular lymphoma. So it was a global study, 1,000 patients enrolled, many in Europe in addition to the US. Patients were randomized up front, and if they were randomized to the chemo arm, the clinician could choose which chemotherapy option, including CHOP, bendamustine, or CVP. If they were randomized to the experimental arm, it was lenalidomide in combination with rituximab. And again, at 7 years of follow-up, you can see there's no separation in this progression-free survival curve or the overall survival curve. So you could potentially conclude that a non-chemotherapy option can achieve very similar outcomes to chemoimmunotherapy. That's not how the study was designed. It was designed to demonstrate superiority of the experimental arm. So it is listed in NCCN as an option for patients, but to date, we're still probably pursuing more frontline chemoimmunotherapy. One study that we've pursued here at Anderson is replacing the rituximab with obinutuzumab, given we know it's a superior CD20 antibody. It has enhanced ADCC and CDC. And when partnered with an immune modulator such as lenalidomide, maybe it's a better chemo-free option for untreated follicular lymphoma patients. So we tried to replicate the R-squared arm in relevance, so that it was 6 cycles of an induction followed by about 18 cycles of a maintenance strategy and then an additional year of the CD20 alone. You could argue that's far too much treatment for patients in the frontline setting, but again, to try and compete with the 6 months of an induction chemotherapy and then 2 years of CD20 antibody, that's how this schema was developed. Again, this was an MD Anderson investigator-initiated study. The characteristics of the patients are outlined here. We did have a good representation of higher risk patients with high or intermediate risk FLIPI score being the vast majority of patients. We also had patients with bulky disease defined as 7 centimeters or larger of their largest mass, and then LDH being greater than the upper limit of normal. What we observed in this study is that patients had a very rapid complete response. So outlined here is the first response assessment in purple versus the best response assessment. And you can see that very little difference in the complete response rates, whether it was the first response or their best response, suggesting that yes, indeed, by replacing the CD20 antibody, you're going to get pretty deep and rapid responses with this non-chemotherapy option. It's immature data, but after 2 years of median follow-up, the progression-free survival curve is outlined here, and it looks quite promising, particularly if we think about historical comparisons, where about 20% of patients are going to progress within the first 2 years. We don't see the similar shape in that curve, and we're getting close to having more mature follow-up on this study where we can publish the results that continue to look very promising. As you would expect with a non-chemotherapy option, the therapy is tolerated quite well. There is some investigator bias here in that the majority of patients who discontinued treatment before completing the 30 cycles, the vast majority stopped at cycle 13, and the vast majority of patients were in a complete response. And so that's based off of our single center experience, where 12 cycles may be as much therapy as you need for these patients. And if there's any potential perceived risk, we're stopping treatment early. And we've since looked at those patients who discontinue treatment early, and they still continue to do well without a signal suggesting that you need longer therapy. We also took advantage of the expertise here at MD Anderson with Michael Green and his group characterizing the microenvironment. As technology evolves, and I'll make another plug, it's critically important that we include correlative science in all of our investigator-initiated studies to address one of those unmet needs, which is a lack of predictive biomarkers. So what we did in this study is we had tumor biopsies on patients pre-treatment and within 1 week of therapy, so cycle 1, day 8. And what you can see here with the single-cell RNA-seq is that we can characterize the microenvironment, including the immune cell subsets, not only T-cell subsets, but NK cells, myeloid cells. And what we observed is by day 8, we saw rapid cycling of T cells, suggesting that our hypothesis was correct. By adding a sort of enhanced CD20 to lenalidomide, you have enhanced synapse formation with T cells that have been activated and tumor cells. And again, it was quite rapid, only after a week of therapy. And that also supports our observation of deep responses at the first response assessment. So again, I do think that this does shed light that we are having efficacy driven by targeting the immune system in patients with follicular lymphoma. So now the next steps are, can we potentially shorten therapy so that we don't have to expose patients to 30 cycles of treatment? Can we further enhance this regimen where we have no relapses, potentially curing patients? And that you could tinker further with the CD20 antibody. I'll show you some data about bispecifics that are emerging, or even enhanced cell mods. So to summarize frontline follicular lymphoma, bendamustine rituximab is one of the most common approaches, mostly because the efficacy is quite good, compares more favorably to CHOP-based regimens, and it has a much better safety profile. The challenges, though, to bendamustine, particularly in the gallium study, is we do see complications surrounding infection and second cancers. And the other issue is negative impact on T-cell subsets. And so as we think about this disease, most patients will have several different therapies. how we sequence treatment becomes important, and what we sequence next with may also be impacted by our frontline approach. Maintenance rituximab can clearly result in a significant first remission duration, but it's not going to alter the natural history of the disease. And again, in this era of viral infections, could potentially put patients at unnecessary risk. Obinutuzumab in combination with chemo can also result in a significant improvement in PFS, but again, there's potentially some concerns about infection rates. R-squared or lenalidomide rituximab can offer a non-chemotherapy option and maybe is a little bit more rational in terms of what we're trying to achieve with disease control, but the challenge there is the duration of treatment. So we still have several options for frontline follicular lymphoma. Again, I'll cover now what's happening in the relapsed refractory setting. This is just a slide demonstrating the number of therapies approved since 2014. So you can see there's a large list here, which is impressive. Follicular lymphoma is rare, and conducting studies in the relapse setting can be challenging. The downside to this is that 3 drugs have been removed from the market just in the last 6 months. So some cautionary tales. All 3 were PI3 kinase inhibitors. And the PI3 kinase inhibitors, there are challenges, particularly in terms of toxicity. And because these therapies are ongoing, so continuous treatment, and particularly over time, you have an impact on Tregs and potentially immune-mediated toxicities such as colitis, pneumonitis, and as well as infections. So as a result, the class has had a sort of a negative perception, and that's unfair given that some of the efficacy looks quite promising. But the challenge is all these drugs were approved based off of single-arm phase 2 studies, and their confirmatory phase 3 studies have been really challenging to enroll, and so all 3 have been pulled from the market. I'll talk to you about R-squared in the second-line setting, an EZH2 inhibitor, tazemetostat. We have Axi-cel, which is CAR T-cell therapy approved for follicular lymphoma, and I anticipate there will be 2 more therapies approved this year, which I'll walk you through that data. So again, how do we define risk in relapsed follicular lymphoma? Due to the paucity of biomarkers, it's primarily defined based off of how they did to their prior treatments. You can see here, lines of therapy generally do result in less favorable progression-free survival. And once we get into that 3rd line or later setting, most patients will anticipate a median PFS of 12 months or less. And then for patients who progress within 24 months of their chemoimmunotherapy, their outcomes are quite poor, particularly when we consider them in comparison to the rest of the population. So again, these are patients progressing within 24 months, and they have a median overall survival of about 5 years. One complicating factor is most of these patients did not undergo biopsy at progression to ensure there's no transformation here. In the era of PET, we do know that probably about 40% of these patients progressing early have evidence of large cell lymphoma and would have potentially been managed differently. So what are we doing in this relapse setting? Well, one approach is lenalidomide and rituximab based off of the AUGMENT study. This is a randomized trial. It's R-squared versus rituximab and placebo. Now, again, is rituximab monotherapy the most exciting treatment in relapsed follicular lymphoma? Not necessarily, but if you think back to that first complicated diagram I showed you, a good portion of patients, at least 20 to 30%, their most common second-line approach is actually rituximab monotherapy. And so in practice, this is a common approach for patients. And you can see here that if you add lenalidomide to rituximab, you have a significant improvement in progression-free survival, and that resulted in a median PFS of 39 months versus 14 months with the control arm, and actually a significant improvement among the follicular lymphoma patients in overall survival. So that then argues that, well, it doesn't really matter what I use now because they're just going to relapse and I'll catch up with that next line of treatment. Actually, by having a more effective strategy as early as second line, you could alter the natural history of that disease. We've also studied obinutuzumab in combination with lenalidomide in relapsed follicular lymphoma. This is another investigator-initiated study. Even though there was a dose escalation component, you can see the PFS and OS looks quite favorable in this relapsed patient population. Again, median follow-up of 41 months, and we've not hit our median PFS. Can we replace lenalidomide with a more potent immune modulator that's being explored. We have this phase 1 study that's currently enrolling. Doesn't have a name yet, but CC99282 is a much more potent cell mod. So in addition to having increased potency to activate NK cells and T cells, there's actually also a component of cytotoxicity, which we've not seen traditionally with lenalidomide. So this might be a very attractive agent. The dose escalation is underway, and we will be launching in large cell and follicular combination strategies, including with CD20 antibodies and other novel targets. But this does appear to be a promising new cell mod that's being further developed. EZH2 is mutated in about 10 to 30% of follicular lymphoma cases. It does appear to be an early event, so testing for this mutation at diagnosis or at any line of therapy can be considered. It's complicated in that it's probably multifactorial in terms of its role. So we know that if you have an EZH2 mutation in a naive B cell, you're going to have B cell maturation arrest, and these cells get trapped in that genotoxic germinal center, and then they're likely to acquire additional aberrations. There's also a role of EZH2 in the microenvironment. And so in addition to blocking it where you might be targeting the tumor biology by blocking EZH2, you may also have an impact on the microenvironment and skew it away from that pro-tumor sort of inflammatory microenvironment to one that could be further augmented to eradicate lymphoma cells. What's quite striking about the phase 2 study that led to FDA approval of tazemetostat is they did try to enrich for the EZH2 mutant population because, again, it's an infrequent mutation in this disease. But in this study, they had a cohort of EZH2 mutant patients and a cohort of EZH2 wild type, and there was about equal distribution across those two cohorts. What you can see here is the durability of response looks to be nearly identical between the two groups. Similarly, median PFS was about 14 months in the mutant population versus about 11 months in the wild type population, so not a dramatic difference. And 11 months actually compares quite favorably to what we can achieve with other therapies in that third line or later space. Again, this speaks to the fact that we don't necessarily need to have the EZH2 mutation to utilize tazemetostat, and indeed it's FDA approved for wild type or mutant patients. So this doesn't necessarily address one of the unmet needs of having a predictive biomarker. The toxicity profile is very favorable with tazemetostat. It's an oral agent, so no grade 4 adverse events have been observed. Grade 3 are infrequent, and the need for dose modification or dose interruptions was quite infrequent. So this therapy does address one potential need in that it can be effective and is generally very well tolerated. The label is slightly confusing. It's available in third line for patients with the mutation or any line in the relapse setting if patients don't have an acceptable alternative given the safety profile is so favorable. As a result of its potential immune modulation, it is being studied in combination with lenalidomide and rituximab. So the phase 1 study, which we have participated in, has completed and was presented by Connie Batleby this year at the ASH meeting. So combining lenalidomide rituximab with tazemetostat with the idea that you're going to further enhance the immune modulation by the addition of the EZH2 inhibitor has been completed. The dose escalation, the safety looks to be very favorable, so no additional or new toxicity observed, meaning fatigue, GI complications, cytopenias are some of the most common adverse events observed. The vast majority are grade 1, 2. No additional toxicity has been observed. Dose intensity was maintained. And it's early, but efficacy looks to be very reasonable. As a result of this study, a randomized phase 3 has launched, which we have open and enrolling at MD Anderson, which is R squared versus R squared plus tazemetostat. So that will eventually answer the question, do we actually see synergy here or potentially additive efficacy without further changing the toxicity profile? Axi-cel, which is an autologous CD19 CAR, is now FDA approved for follicular lymphoma in that third line or later space. That was generally led by Satvanilappu and large contribution by our group at MD Anderson. But this took patients with either follicular lymphoma or marginal zone lymphoma who had failed at least 2 prior lines of therapy, and that had to include an alkylating agent. So patients who'd had what was perceived to be more intensive prior therapy. Similar to CAR T and large cell lymphoma, patients underwent leukapheresis. Manufacturing took approximately 17 days. They then proceeded with lymphocyte depleting chemotherapy and a one-time cell infusion of axi-cel with post-monitoring, with objective response rate being the primary endpoint. Observed here, very high response rate with axi-cel in relapsed follicular lymphoma. Again, the majority, nearly 80%, achieving a complete response, which is some of the most highest objective response rates and CR rates we've seen to date in the relapse setting, and almost mirroring what you can achieve in frontline. When we look at the progression-free survival and overall survival, again, quite favorable with CAR T-cell therapy and relapsed follicular lymphoma, which is why it's been FDA approved and is an option for patients. One potential criticism is we don't see the traditional Kaplan-Meier curves that we're accustomed to seeing with large cell lymphoma, where we have pretty rapid drop-off in the first 3 months, but then a plateauing of that curve. And we know in large cell lymphoma, we're curing 40% of patients with axi-cel. In you don't see a steep drop-off in the first 3 months, and it's actually more of a slow decline over time. And these out here are very small numbers, so we haven't seen that plateauing of the curve to suggest that we're curing a large portion of patients. But you can also argue that this results in some of the best efficacy we've observed to date in the relapse setting. So now the question is, should we be considering CAR T-cell therapy for every patient in third line or later follicular lymphoma? It's hard to make an argument as to which subtype performs better or worse with this approach. I think one potential limitation is the toxicity profile and potentially the healthcare resource utilization. As I mentioned early on, many of these patients will have favorable outcomes. They have a number of treatment options available to them. CAR T requires referral to a specialized center like ours. Patients have to spend at least 4 weeks within a 2-hour vicinity, according to the REMS program. Some 15% in this setting ended up in the ICU as a result of grade 3 or higher neurotoxicity, which all recovered. But it is a little bit challenging for particularly the community oncologists who are managing follicular lymphoma to really understand who would you consider a referral for with follicular lymphoma when the perception is most patients are likely to do well. Well, one option is to consider a CAR T-cell therapy with the perception that the toxicity profile is much more favorable. So T-cell is another autologous CD19-directed CAR, but it has a 4-1BB construct. So you have far less acute toxicity than what we've observed with axi-cel. And then there's more persistence potentially, which might be an attractive option with this construct. So the ALARA study enrolled follicular lymphoma. We also played a role in this study published by Nathan Fowler in the last few months. So this only enrolled follicular, no marginal zone lymphoma patients enrolled on this study. They did allow for bridging chemotherapy because there is a longer time for manufacturing, which in large cell lymphoma can be a challenge. In follicular, my opinion, is less of a concern because most of these patients, 4 weeks in the timeline of 20 years is a really short period of time. Slightly different lymphocyte depletion, either in terms of dosing of fludarabine or cyclophosphamide, but also the option to utilize bendamustine, which we know has activity against follicular lymphoma as well. And based off of the single-arm ALARA study, again, the toxicity profile looks to be quite good. So no grade 3 or higher CRS, one patient with grade 3 or higher neurotoxicity, which did recover. And about 20% of patients were able to be infused outpatient, which might address the concerns about cost. Now, in terms of efficacy, CR rate was the primary endpoint in this study, which was 69%, which again is quite good in terms of historical comparison. And I would caution anyone about trying to compare these two studies, the ZUMA-5 or ALARA, because they were different in single-arm phase 2 studies. But again, durable responses observed with T-cell, maybe a little bit of a hint that it should be used in earlier lines of therapy because those patients with 5 or more lines of therapy did not benefit as much, those with high metabolic tumor volume. And then those with a POD24 status did not do as well as those that did not have these features. So again, we do potentially have options that are better tolerated, can be done in an outpatient setting, so less costly to the healthcare system at large, and can achieve reasonable efficacy and durability of that efficacy. Another study that we've completed enrollment for the follicular patients, we should be hearing results in the next year or so, is utilizing JCAR or Lysocell, which is another 4-1BB construct, also approved for large cell lymphoma and transformed disease. So you can see there were a number of different indolent lymphoma cohorts, but the follicular has completed enrollment. Can we utilize a different cellular therapy product? NK cells provide some advantages, particularly in regards to toxicity. So there should be no CRS or very little, no neurotoxicity. Graft versus host disease is not a concern. You could potentially take an off-the-shelf healthy cell that's not been exposed to prior therapies like bendamustine and infuse in these patients. And so Katie Rezvani and EJ Schwal in the transplant group here developed an NK CAR derived from cord blood utilizing lymphodepletion, and then a dose escalation has been completed with 800 million flat dose cells being chosen as an expansion. And what we saw with these NK cells, very favorable toxicity profile. Again, no grade 4 adverse events observed. The only one grade 5 was due to patients that died as a result of disease progression. And even the grade 3 adverse events are very infrequent and more likely due to the lymphocyte depletion than anything else. One grade 1 CRS that resolved without intervention, such as tocilizumab or corticosteroids, again suggesting that this is a very well-tolerated therapy. And if you look at small numbers, but the efficacy observed in indolent lymphoma, which included follicular and marginal zone lymphoma, quite favorable, and again compares quite well to what we just saw with Tisa-cel. As a result, Takeda has now licensed this. It's called TAC-007. It's a cryopreserved cord blood-derived NK CAR, and it is being studied in 2 cohorts, including large cell and indolent lymphoma, and is now open across a number of centers. And so we're excited to have this opportunity for patients, and I think particularly for indolent lymphoma, this will provide a very safe option for patients. So to summarize cellular therapy, we've seen some of the best response rates in PFS to date in that 3rd line or later space. And I will, in my opinion, think that that is in highest risk patients. So over-enriched with POD24 patients, those double refractory to chemo and CD20 antibody, and those that are progressing quickly through a number of therapies. I do think the safety profile is likely impacted uptake, particularly across centers where they don't have access to CAR T. I think defining the optimal candidate still remains somewhat challenging. In my practice, I will consider this for POD24 patients at that 3rd line time point. I will consider it for any patient where the follicular lymphoma is behaving like it is transformed, though I may not have proven it with a biopsy. And particularly for my young fit patients where I'm trying to get them 20+ years in a large portion of that time period in the absence of treatment, I will consider CAR T. I think we'll have more options available in the next few years, including Tisa-cel, which maybe has a more favorable toxicity profile, and then Lysocell is coming down the pipeline. So how will we choose when we have more than one option? I think particularly in indolent lymphoma, if the efficacy is comparable, safety will likely be the deciding factor. The other therapy that's coming down the pipeline are the bispecifics. So this is kind of in between your CD20 antibody and your CAR. Does not require leukapheresis or manufacturing, so logistically it's a lot easier in a sense than CAR T-cell therapy. There are a number of bispecifics being developed across B-cell lymphomas. Mosunetuzumab probably has the largest sample size right now in follicular lymphoma and is anticipated to be FDA approved for follicular lymphoma. So it targets CD20, CD3. You can see the construct here. The enrollment for the follicular lymphoma phase 2 includes 1 through 3A, and similar to the CAR T population, they had to have failed at least 2 prior lines of therapy, which did include an alkylator and CD20 antibody. Because of the toxicity profile, which I'll highlight in the next few minutes, which most commonly includes cytokine release syndrome, a number of strategies have been employed to try and mitigate this. One successful strategy is a dose step up or ramp up where patients low dose on day 1, a little bit higher dose on day 8, and then full dose by day 15. And then they're continued every 3 weeks at 30 milligrams for up to 8 cycles. If they're in a CR, they can stop, or 17 cycles if they fail to achieve a CR by 8 cycles. I do think there are some advantages to that. So it's not chronic therapy. It is time-limited treatment. And the dose intensity is really just during the first cycle, where every 3-week dosing beyond the first cycle is in line with what we commonly do with other regimens. In regards to the patient population, you can see the median number of prior lines of therapy was 3, and most were refractory to their last line of therapy, nearly over 2/3 of the patient population. And again, overrepresentation with these high-risk groups such as POD24 and those that are double refractory. The primary endpoint in this study was response, and you can see here objective response was quite high, CR rate was quite high, and the waterfall plot demonstrates that the vast majority of patients had a reduction in tumor volume, suggesting this is an effective strategy for many patients, and the median PFS is outlined in this slide of nearly 18 months. So I do think this will be an option for patients. I think the toxicity profile is potentially more favorable than CAR-T, but still has CAR-T-like features. So cytokine release syndrome is one of the most common adverse events observed. The vast majority are grade 1 or grade 2. Infrequent to have grade 3 or higher CRS, followed by neutropenia as one of the other more common grade 3 or higher adverse events. Treatment discontinuation or modification is very infrequent. So in my experience, the first cycle is generally when most of the toxicity occurs, with the exception of neutropenia, and then beyond cycle 2, most patients essentially tolerate this very well with very few complaints. And the patients with follicular lymphoma that we enrolled on this study have done incredibly well, stopping after 8 cycles of treatment, and many have remained in remission now, extending well beyond 2 years. As a result, now these combination strategies are being explored further, and I've shared a lot of slides looking at targeting the microenvironment with lenalidomide combinations, either rituximab or obinutuzumab. So I alluded to this. A phase 1 has been completed with mosunetuzumab in combination with lenalidomide for relapsed follicular lymphoma patients. You can see the study schema. Lenalidomide, because of its immune modulating properties, is introduced at the beginning of cycle 2, again, as a strategy to try and avoid creating more cytokine release syndrome. The results of the phase 1 were presented at our ASH meeting, and you can look at this here, but in my experience or opinion, it looks quite favorable to what we see with mosun alone, very similar, if maybe not even more favorable than what we see with R-squared. So cytokine release syndrome was observed, but was generally low grade. Neutropenia was similar to what we see with lenalidomide-based therapy, so no additive toxicity, and the efficacy looks to be quite good, even considering that this was a dose escalation study. Objective response rates approaching 90%, and then among those poor risk groups, again, reasonable efficacy. As a result of this phase 1 study, again, open at Anderson, we have a randomized phase 3 underway for second line or later patients looking at R-squared versus mosunetuzumab, which we're quite excited about. So to summarize the bispecifics, the early results look to be quite promising with, again, quite favorable response rates and median PFS that outside of CAR-T looks to be more favorable than what we were achieving with historical controls. CRS does appear to be a class effect, but it seems to be confined to the first cycle. It was mitigating strategies such as dose step-up or more aggressive pre-meds. One other approach that's being studied right now is a subcutaneous administration, which leads to a little bit more blunted absorption. That also is being explored and might provide additional strategies to reduce that risk. I think in general, bispecifics look to be very promising and will likely have more uptake than CAR T-cell therapy, given it will likely be used outside of specialized centers and will likely move into earlier combination strategies. So this is my last slide before we launch into the Q&A. how do you navigate the current treatment landscape and what do I anticipate will change? I think for most patients in frontline who are appropriate for therapy, and we didn't talk about this today, but there is still a role for observation because we're playing the long game here. We're trying to get patients well beyond 20 years with their disease. And so the longer I can delay that first therapy and potentially expose them to risks, I think the better. So for patients who are appropriate for therapy, most of frontline chemoimmunotherapy, we're having a lot of debate right now whether or not we should forego bendamustine altogether, particularly as we're utilizing more and more immune-based therapies, and we know bendamustine can be detrimental to T-cell subsets. But I would say most patients are still getting a BR frontline approach. At relapse, depending on when they relapse, if there's any concern for transformed disease, I would strongly encourage a biopsy just to make sure you know what you're treating. For patients who have no evidence of transformation, then your second line approach is really kind of based off of what they had previously and how long their remission response was. So you have a number of options. My preference actually is to pursue R squared in second line based off of our experience, and the idea that my third line or later approach is either going to be a CAR T or a bispecific. And so if I can potentially not have a harmful impact on those T cells and maybe even potentially augment them with an immune-based approach, that might have an impact on my third line or later setting. And then EZH2 I reserve for my post-CAR T failures, though again, it might move into earlier lines. The PI3 kinase inhibitors, we only have one available to us now, copanlisib, and so I do think that will be reserved for later lines of treatment. So to conclude, I think most patients with follicular lymphoma should anticipate very favorable outcomes. However, we need to do a better job risk stratifying patients so that we can actually balance their goals and our goals, which is to achieve a durable disease-free interval that does not have a negative impact on their quality of life. We still have several questions that need to be answered, so I would encourage all patients to seek an opinion at a center like ours or an academic center so that we can help the population at large by understanding, can we ever identify predictive biomarkers? Can we identify optimal sequencing strategies? And can we ultimately find a cure or one that can at least result in prolonged disease-free intervals and time away from us? I think at the end that would be a success. So with that, I appreciate the opportunity to participate. I really appreciate our host, Dr. Kalin. I know Dr. Ferrajoli is not here today, Dr. Greta, for this opportunity to share what we've been doing to help improve outcomes for patients with follicular lymphoma. With that, I'm happy to answer questions.
Thank you very much, Dr. Nastopoulos. It was a wonderful talk with a lot of information for us, the scientists, clinician, and patient. And I start with the first question. How do you see the correlation with the molecular profiling? For example, no BCL2 overexpression, BCL2 mutation. What do you think? Such correlation would help you in further refining the therapeutics?
That's a really interesting question and one that I've struggled with over the past 2 years. So the hallmark of follicular lymphoma is translocation 1418, which leads to overexpression of BCL2. The challenge there, though, is that we have BCL2 targeting therapies now. We have venetoclax and a number of others that are being explored, and they have very little activity in follicular lymphoma. So why is that? Well, the simple answer is we don't fully understand. I think the long answer is that translocation 1418 is probably the first hit in this disease, but there are other things that accumulate over time, and particularly the epigenetic alterations that can lead to immune escape, but also trapping those lymphoma cells in that genotoxic germinal center environment, where then they acquire additional genetic aberrations that eventually lead to that tumor. And then the impact of the microenvironment where it sustains that tumor in that sort of pro-tumor microenvironment. So I think most of our efforts have been on not just trying to target BCL2, but trying to target that pro-tumor microenvironment. I have some optimism that things like tazemetostat that are more targeted at that epigenetic alteration might have a larger impact than things like BCL2. But for our diagnostic purposes, BCL2 and translocation 1418 are still critically important. It's just from a functional standpoint, we've been focused in other areas in terms of having effective treatment strategies.
Thank you very much. And a second question, also about molecular biology. Did this patient have deletion or reduction in expression of P16 tumor suppressor?
That's not one that has been commonly described, so not to my recollection. I think generally CRED, BBP, EP300, these are the most common alterations that we see in follicular lymphoma. Not aware of any others at this point.
Thank you. And also, what is your opinion? So, what is your opinion about the next future step in the therapeutics of follicular lymphoma? Current K, be specific. So, how you envision the next 10 years in the treatment of this disease?
Yes, what I think is going to happen is we're going to have bispecifics move into frontline, and they're going to be combined with cell mods. It'll probably be the next generation cell mod, either 282 or there's iberdomide, which is another one that's being explored. The question will be, will we actually achieve cure, or will we still have the same number of patients relapse? And then in that second line space, we have targeted therapies on top of the R-squared backbone like EZH2, and then we still reserve our CAR-T for that third line or later space, or CAR-NK or allogeneic CARs. I anticipate that's sort of how this will evolve. The question is, are we going to move away from chemotherapy altogether? I would like to see that happen, but there's probably some situations where that will not be true. For any patient with transformed disease, we still are using an anthracycline as our frontline approach. We know that CAR-T works really well in the post-anthracycline failure. And the other place where chemotherapy can be helpful is particularly for our really old patients. And the reason I say that, so for older patients, if you dose adjust your bendamustine appropriately, you could potentially get away with 4 cycles of BR, and you may never have to treat those patients again. So I think there's still a role for clinicians applying their sort of art of medicine while we spend a lot of time trying to figure out, can you identify patterns in the biology that selects out the treatment option when you have a number of options available for you. But at the end of the day, what we're really trying to achieve is disease control that results in fewer treatments. And so I don't dismiss that there probably will still be a role for a short course of chemotherapy, particularly for our patients where that time-limited treatment might be a major advantage.
Thank you very much. And in the continuation of the previous question, Max Gordon is asking, beyond the treatments you discussed today, what novel targets, probably protein targets, do you think are most promising for follicular lymphoma?
Yeah, the one area that I didn't spend any time talking about, but probably will have a role, is targeting or enhancing the utilization of macrophages in our approach to treating this disease. So the CD47 SIRP alpha axis looked to be very promising early on, particularly when combined with rituximab. And so those studies are still underway. The question will be, do we use them alone or do we have to combine them with CD20? And at what time point would you utilize them? Paolo Strati in our group has showed some interesting data that patients who fail R-squared or lenalidomide, one mechanism might be through enhanced macrophage activation. And so can we use a sort of macrophage checkpoint inhibitor like a CD47 antibody or SIRP alpha antibody? That might be one strategy to address that sequence of failure. I think the other area that we're still struggling is, again, how do we utilize BCL2? And so there are a number of degraders or targets that not only target BCL2, but BCLX. And so it might be that it's just the balance of those proteins that needs to be addressed as opposed to just targeting BCL2. So there's still opportunity and studies underway there. So we might have figured this out in the next few years, and we'll be utilizing the BCL2 targeting as well. And then the last thing I will say is, can we actually identify those patients where an immune therapy approach is really just not the optimal strategy? And that's where things like bendamustine or CHOP-based therapy can be very useful. So Michael Green has done some really interesting work similar to Steve Ansel at Mayo, just looking at the tumor microenvironment and what T cell subsets are present and sort of characterizing it as sort of a cold or a hot microenvironment may then help us select personalized approach to patients, and maybe we can identify those that are going to do really well with immune therapy versus those that really we should just hit them with chemotherapy because there's really no immune cell subsets there to activate.
Thank you very much. So with this, thank you. It was a wonderful talk. Thank you all for participation. Thank you, Dr. Nastopil, for these excellent ideas. And now we have to tell you that we are looking forward to seeing you in the fall. The spring session finished with a wonderful speaker and a wonderful talk. And we wish to all of you to have a fun summer, enjoy life, and of course, enjoy science. Thank you again, Dr. Nastopil. Thank you to everybody who are supporting Enjoy Science. Good luck with everything.